like I'm in a giving mood. So there you go. So thanks for all the feedback there, and we'll get started here. So when we look at what's going on with heart disease, the objectives today is to talk about cardiovascular disease. And under the cardiovascular disease umbrella, I'm going to talk about hypertension, and I'm going to talk about dyslipidemia. Dyslipidemia is obviously abnormal cholesterol levels. And I'm going to talk about options for treatment. So I'm going to talk about medications. I'm going to talk about their benefits and side effects. And Tanya is going to, of course, jump in and chime in on that aspect of things. And then I'm going to talk about supplements. And everyone has questions about interactions that are there. And again, if you have any questions that are specific today, I'll do my best to answer them, or Tanya will be doing her best to answer them on the go. But you can use the chat box, or you can unmute yourself at the end, and we'll go through that part of it. So this is my objective today. If you have any other objectives or questions that you'd like to get through, please put them in the chat box, and I'll do my best to attend to them today. But there's so much. Literally, I think we can do probably 3 or 4 webinars just on medications and supplements and interactions that way. So we can definitely go through lots of things on that effort. So that's my objective today, and what we're planning on going through this on this part of it. So no presentation gets complete if I don't bring this slide up. So arteries are a muscle. They're not a pipe. It's not cholesterol accumulating in this pipe and you have a last piece of fried chicken and you end up with a heart attack. It does not happen that way. And so I can't stress this enough. I mean, it becomes very important to understand this concept so that you understand that these arteries are not a plumbing problem. And people think, oh, we got to fix it with bypass and stents. And there are important times and places where we should put that together, but it's not always the case. And I talk about cholesterol and golf balls and tennis balls, and most of you have come in and done this testing with us in the clinic. Golf balls are small. They're more atherogenic or plaque causing. They can sliver into the lining of the artery wall. And tennis balls are not. They're large and fluffy. And it doesn't matter if you have lots of them. So if you have high cholesterol that are tennis balls, it matters not. And so LDL is important to understand that it comes in different sizes. And I talk about this slide as well. I apologize if your name's David or Maria, and I know a lot of you out there are. So I apologize for that in advance. But the smaller particles are more atherogenic or plaque causing. They're the ones that can sliver into the lining of the artery wall and start to cause havoc. And when we look at the other aspect of things, with Jerry and Susan, that's kind of where you want to be. Those are the large, fluffy cholesterol particles that are very important. So again, I want to reiterate this part of it because it always comes back down to where do supplements help and where do medications help? And so when we look at the artery is a muscle, right? Not a pipe. And so when we look at this, first thing that happens is something has to hurt that lining of the skin. And when that gets hurt, then these small particles sliver into the lining of the artery wall. And when it gets broken down there, just like a sliver would inside the skin, it gets broken down. Then you get an immune response. These white blood cells come and eat this stuff up. And now it becomes a macrophage, a foam cell, and then it becomes a plaque. And there's a whole plaque building process that happens here. And so this is what we're trying to achieve there. The chemical reactions that happen here are the reasons, right from 1 to 40 plus, are the reasons why we're taking supplements or even medications. And it's to help with the artery wall on that side of things. So if you've had an angiogram, this is the gold standard for looking inside the artery wall. But you do not want to have this test if you do not have symptoms of artery disease. And that includes if you've already had a stent or bypass. This is a very invasive test. And there's a time and place when we should be doing an angiogram. This is a catheter that comes right into the wrist. It comes in right in through the wrist. It comes right to the arteries of the heart. And then we flush an artery with dye. And then we can see where the plumbing problem is. And there's a difference for when we look at it at this level versus looking at it in the healthcare system. Ideally, I would like to be looking at it at this level, but this is where we normally look at it in the healthcare system. You do not want to be doing this test unless it's an emergency, unless it's an emergent situation. When is it an emergent situation? Is if you're having acute coronary syndrome, if you're having unstable angina, if you're having, so you only want to be doing an angiogram if you're in the emergency room. And that's the only time you want to be doing this. And people keep on telling me, well, Diamond, I want to pay for a private angiogram. I want to be able to look at this. You don't want to do that. You only want to do this when you are actually having emergency. So doing an angiogram is not a good idea. But if it is an emergency, then at that time, this is where cardiologists really excel. And when they really excel, this is where they can put in a stent or perhaps a bypass surgery. And that's important so that we can open up that artery quickly after an acute coronary syndrome, if they're having acute angina pain, or if you're having an active heart attack, or it could even be bypass surgery because sometimes the arteries are not amenable to a stent. And whether you've had a stent or bypass surgery, the next step is to then do optimal medical therapy. And this is really what we're going to strive on today, is we're going to talk about medications, specifically these ones that are involved in optimal medical therapy, and then what we can do to then really focus on supplementation, because medications only get you so far. This is where we want to take it a step further. And I have a very important thing here, and this is really what I want to highlight. After an angiogram, they might do a stent, they might do a bypass surgery and optimal medical therapy or optimal medical therapy. And when we dive into optimal medical therapy here, this is where the studies have shown optimal medical therapy is as good as doing a stent or is as good as doing a bypass surgery. And that makes me think, that makes me puzzle. But that's where you're not listening to me at the beginning of this stage of this arteries, that these arteries are a muscle, not a pipe. And this is why strong literature has showed that optimal medical therapy is a treatment option versus doing a stent or bypass when the artery is stable. This is not when you're having acute coronary syndrome, if you're having unstable angina, or if you're having a heart attack. This is not the same thing. So let me reiterate this. If you go and you do a stress test and you find, we've got a plumbing problem, we decide to do a nuclear test and we find, we got more plumbing problems. Now let's do an angiogram. I don't necessarily agree with that step. When we should be doing an angiogram is if you are in the hospital with artery disease. This is when you want to be doing an angiogram. This is when you want to be doing that. And then we want to be able to perhaps do a stent or a bypass, or medical therapy is just as good as a treatment option. And let's go through that part of it. So what is optimal medical therapy? I'm gonna turn it over to Tanya here, and hopefully you can see.
Sure. Can you hear me, see me? Okay there? I think so. I can't see anything. So I'll let you admit people now.
Perfect.
We've still got a few people joining. We're at 62 people. Thanks for joining us, guys. Just looking at optimal medical therapy. So like Diamond said, this is something that's often used in conjunction with a heart stent, or sometimes in replace of a heart stent altogether. And so looking at optimal medical therapy, there are 4 main classes of medications that we typically use. So antiplatelets, beta blockers, ACE inhibitors, and statins. And we're going to go through those one by one, just explaining the differences, why we use them, what benefits they have, and what potential side effects you might experience as well. So starting off with the first one, so 8 antiplatelet and anticoagulant drugs. So these are the classes where we're talking about aspirin and we're talking about Plavix, or what you might hear as clopidogrel. There's another name for the other drug called ticagrelor, or we use generic names and brand names that you'll see 2 names for every drug that we talk about tonight. And so the way that these drugs work is really essentially they're making the blood thin and making the platelets less sticky. So going back to that initial diagram that Diamond was showing us here, is that this is preventing those platelets, that plaque formation process, from occurring. What it's doing is it's making sure that these platelets slide across each other and they don't clump together. And so talking about aspirin first, we wanted to get into some of the literature around that.
Yeah, and this is aspirin would not be an over-the-counter drug today in the healthcare system. So when we look at aspirin, and if it were to come out on the market today as a drug, it would have to go through the trials and all that aspect of it to become an over-the-counter drug. I don't think it's an over-the-counter drug today. And the reason why is there are amazing benefits of aspirin, but there are also some safety effects that we have to be concerned about that. So this is for primary prevention. So for those of you who have not had a heart attack or a stroke, myocardial infarction, so the number needed to treat. So I'm going to talk about that a lot today. So I'm going to explain it right now off the get-go, is that the number needed to treat is how many people need to be walking in to the office for Tanya to prescribe aspirin. How many of those can we prevent a heart attack or myocardial infarction? And the number is 357. So that means that 357 people need to be walking in to our office, to Tanya's office here. I'm in Tanya's office today. You know, how many people need to be having, you know, that heart attack? That's what we're really looking for on that side of things. So the number is 357 people need to be walking into the office to prevent one heart attack. Now, there's other things to look at. Is the number needed to harm? How many people need to be coming into the office for one person to harm? And that's 222 in this. So the adverse effect of bleeding is 222. So you can see that this ratio already is off. That, wait a minute, 357 people need to be walking into the office to benefit, but 222 people are going to have a major bleeding effect. Not a minor, a major bleeding effect. Minor bleeding can happen often, and we'll get into that, of course, today. And so ischemic stroke, the number needed to treat is 500. Intracranial bleed, so that's a hemorrhagic stroke. So there are two different types of strokes. There can be an ischemic stroke where it closes up and narrows, or it could be a hemorrhagic stroke where the artery bleeds. Well, that is 1,000. So that's a little bit better of a ratio, right? Transient ischemic attack is kind of like angina for the brain. The number needed to treat is 370. A gastrointestinal bleed is 385. Or major adverse cardiovascular events is 263. So there are side effects that happen from taking a drug. There's always benefits, but there are always side effects. And the reason why we're taking the drug, as Tanya mentioned, is to focus on limiting that side of things. So maybe you can talk about the other drugs that you were talking about already. And so it always comes with a brand name and the generic name there. Yeah.
That's right. And so going back to these two drugs here, so these are our anticoagulants, our ticagrelor and our clopidogrel, and these are the words that till this day, doesn't matter how long I've been in healthcare, still have trouble on the tongue. But these two drugs are essentially used, like I said, to keep the platelets slippery. And the main use for these two drugs is not necessarily for primary prevention, but this is in the case of where we actually have a stent that is put into place. And so when a stent is placed into the actual artery, and we can move on to the next slide just to show the picture here, is that that stent is foreign to the body, right? So that's something that your body doesn't normally have in place. And when that metal is introduced into the body, what we need to do to make sure that the body doesn't naturally clot it off, right? Just like it would to any injury, that clotting cascade begins. These drugs are used to make sure that the blood stays slippery. And typically this drug will stay on board for at least up to a year. And so the choice, at least when I started back in nursing, Plavix was the only thing we had. And now we've added the new kid on the block, which is not so new anymore.
Yeah, and this is very important to understand, because if you have a blockage, right? Here's a blockage, you've had a heart attack, and doctor comes in and says, you know what? We have a plumbing problem. We got to open this up. And this is very important if you're having an active acute event. Now we want to go in and we put in a stent like this. It balloons open. And what happens is that when it balloons open, we're actually injuring the artery wall. Right, Tanya? We're actually injuring the artery wall.
That's right.
And so what happens is that then we deflate the balloon and then we pull out the guide wire and we leave this mesh. This metal mesh hurts. You actually start an inflammatory cascade to the artery wall. That's why I can't stress this enough. And I'll say this 1,000 times and 1,000 times more. Arteries are a muscle, not a pipe. And when you look at the artery, we're actually hurting the lining of the skin when we put a stent. So here's where it comes the savior saying, okay, if we're putting a metal object inside the artery wall to open it up, now we want to prevent the normal reaction. So think about this. When was the last time that you hurt your skin or scabbed your skin? You underwent an inflammatory cascade where it bled and then it scabbed over. We're trying to prevent that from happening. So we're trying to prevent the healing, the natural healing mechanism that happens when we have a stent placed. And so this is the reason why that you're on these blood thinners, is to thin the blood so it doesn't give a chance for the artery for the stent to close up inside, because these arteries are not very small. They're about the width of a quarter, right? And so if we start to bleed and start to cause a scabbing process, we can have what we call in-stent stenosis. So now now you have this disease that comes out inside the actual flow of the artery. So this is where it becomes important to look at that part of it. And this is where optimal medical therapy comes into play, is that this is why optimal medical therapy is just as good as a treatment option as putting a heart stent. And again, I'll stress this again and again. I know we have some cardiologists, maybe even some doctors online today, is that these arteries, and they can pipe in and talk about this, but these arteries are, there's a time and place when we want to be able to put in these procedures. And that's where it becomes very important.
And so this slide here is, again, just summarizing those two classes of drugs, the antiplatelets and anticoagulants. Essentially, both of these drugs work to prevent that thrombosis or that clot formation to happen. So again, just reviewing that, aspirin, clopidogrel, ticagrelor, those three drugs keep platelets from adhering to each other. They make them less sticky, slippery, so that they don't clump up. Whereas the anticoagulants, drugs like warfarin, dabigatran, rivaroxaban, apixaban, and again, the names that you're seeing in brackets, those are the brand names. The names I'm referring to are the generic names. And so every drug has two names, sometimes even more than that. But these are your blood thinners. And these drugs typically, these anticoagulants are typically used in scenarios where we might have atrial fibrillation, or a previous clotting issue that we would need to be on, whether it be short-term therapy or long-term therapy. And both classes, we've lumped them together because essentially they both have the same risk, which is that bleeding risk that Diamond mentioned. And that's that risk of bleeding that can happen either in the brain or the GI tract. And these are things that we often see in a hospital is patients coming in that have been on anticoagulation for maybe it's their stent, maybe it's a previous clot, whether it was in the lung, whether it was in the leg, but suffer a complication of these drugs. And so really what we want to do is weigh the benefits and risks for each person when they're on these medications.
And so a common side effect that happens, and I see this, gosh, so much. For those of you who don't know this, I'm aging myself, but I already told you my age at the beginning. So I've been in this field since I was 23-ish, around there. So it's a long time now. So since 99, I've been in this field. There are so many people that get prescribed a proton pump inhibitor because these blood thinners are causing a side effect to the GI tract. And now this just puts you into a merry-go-round of, okay, now we're healing the gut, but we're hurting the gut, now we're hurting the arteries, and we end up with this merry-go-round. So proton pump inhibitors, I can confidently say I'm 100% against. I think those drugs should be thrown away. Why? Because I'm an artery guy. And these drugs, yes, they heal the guts. Actually, let me rephrase that. They cure the symptoms of what you can get from acid reflux, but it really hurts the artery wall. And 90% of diseases start in your digestive tract. And so now this gets into a whole gut health issue. And, I could do talks on, we'll be doing talks on that part of it, talking about gut health specifically. But proton pump inhibitors are a side effect from the symptoms that happen with this antithrombotics. And so when we look at the risk of proton pump inhibitors, it makes you deficient in B12, magnesium. Magnesium is responsible for something like 400 different biochemical pathways in your body. It's obviously increases the infection rate. It affects the GI tract. It thins it out. And so believe it or not, the artery wall, if I showed you a picture and getting zoomed in on the artery wall, which I've showed before, and if I zoom in on the gut, the mechanisms of how the biology and the pathophysiology that happens at that cellular level is very similar to what happens inside the lining of the artery wall. It increases the risk of adverse cardiovascular events. Okay, we're taking a drug to stop heart disease, but now we're taking a drug to bring it back. It doesn't make sense. It increases the risk. Sorry, let me go back there. It increases the risk of kidney disease. It increases the risk of dementia and increases the risk of fractures. So proton pump inhibitors are a no-go in our books here. And it's important that if you are taking this, that you have a conversation with us, because you want to take yourself off of these safely and effectively.
Right. And the only thing I would add to that too is that each case is individual. So if there is a reason that you're on it, then we would look at ways to promote your gut health overall. So moving on to that next class there that Diamond's brought up is beta blockers, right? So beta blockers are a drug that in optimal medical therapy, in this scenario, what they're typically used for is any symptoms of angina or symptoms of ischemia. And what we mean by that is, again, when there's any narrowing or blockages of the arteries, the heart is a muscle, so the heart needs that oxygenated blood. And if the heart is not receiving oxygen, those symptoms is your heart saying, I'm not getting enough oxygen. And so that's what beta blockers are used for in this scenario, but they can also be used for different mechanisms in heart failure, as an antiarrhythmia for people that might have atrial fibrillation, and a few other scenarios as well. But we'll talk about beta blockers in optimal medical therapy. So the way that beta blockers work is essentially, I mean, again, we're going to go back to how your heart is innervated. And so when we think about our heart rate, we've got a sympathetic response and a parasympathetic response. And there are different catecholamines or certain hormones that are released, adrenaline, noradrenaline, that allow your heart rate to speed up in that fight or flight response. And so what beta blockers do is they affect the natural pacemaker of the heart. So the SA node, which starts that heartbeat that then travels over to the AV node and then eventually innervates our ventricles here. And so the beta blockers, essentially what they're doing is they're slowing that SA node, which then in turn slows down your heart rate. And being on beta blockers has the benefit of also dilating your arteries and lowering blood pressure.
So one thing to think about with beta blockers, and I know it's part of optimal medical therapy, but if you have too low of a heart rate, this might not be the medication for you to be on. Mm-hmm. And, you know, another thing is that it also, in my opinion, I think I'm a big fan of using these medications more if you have heart failure or angina symptoms. I think that's a big key on that. Or if you have an arrhythmia, that is important to control the SA node on that level.
And so going back to the beta blockers, so again, we see two names for every drug we're talking about. What you'll typically see with beta blockers is they end in that LOL, and not to be funny, but they end in LOL. And so again, they have great benefits for your heart overall, but there are some side effects that many people face. And especially in that first 2 weeks of starting this class of drugs, people can often feel dizzy. They may feel lightheaded. They might feel quite lethargic. And that's really because we're literally slowing down your heart rate. And then the other side effect can be erectile dysfunction, because again, that is all vascular blood flow. And then the next class of drugs that we'll talk about in optimal medical therapy is ACE inhibitors, or ARBs. And so to explain this a little bit more, this is a drug that's used for, again, a variety of reasons. There are two classes, and typically what we like to start with are ACE inhibitors. But before I talk about the drugs, what I want to explain is this system called the renin-angiotensin-aldosterone system. And so not to get too geeky on you guys, but what I really want to help explain here is that this system essentially is controlling our sodium and water reabsorption. And so when we think about renin, the initial stage of the system is renin is released from the kidneys. And essentially it's released when there is, our body senses that there is low blood pressure or low blood volume. And so it secretes renin, and our liver secretes angiotensinogen. And so this then goes on to angiotensin 1. And for angiotensin 1 to convert into angiotensin 2, there's an enzyme that's released from the lungs, and that's the angiotensin converting enzyme. So when we're talking about ACE inhibitors, or angiotensin converting enzyme inhibitors, what those drugs are essentially doing is stopping that enzyme so that we don't convert angiotensin 1 to angiotensin 2. And the reason that is because the angiotensin 1 essentially is, once it converts to angiotensin 2, it tells the blood vessels to vasoconstrict or to essentially narrow. So what in effect that does is push volume up and cause your blood pressure to go up. And oftentimes, and I'll get to this on the next slide, but maybe we'll go back and forth, we'll go to the next slide, but when you're looking at ACE inhibitors, that most people will typically, I shouldn't say most people, but a common side effect of ACE inhibitors is getting this dry, persistent cough. And that cough is essentially because the way that drug acts is on the lungs. And so that's why people often feel that cough. And so if an ACE inhibitor is not working, that's when we might consider an ARB instead. Okay, and then when we're talking about the ARB, the angiotensin receptor blocker, is what it's essentially doing is blocking the effect of angiotensin 2. So again, it's having the same effect that an ACE inhibitor would have in terms of keeping those vessels from not vasoconstricting, but allowing them to vasodilate. And essentially what it causes is it tells the body to then release sodium so that water follows salt. So this is a key thing to remember, is water always follows salt. And aldosterone, when that's released from the system, tells your body to absorb salt. And so what we want is actually an effect for your body not to hold on to salt, so that water follows it. And that in essence brings down your blood volume, your blood water, and your blood pressure. Hopefully that makes sense.
Yeah. And this all makes sense because obviously the side effects that come from it, and an increase of potassium levels and the immune balances, but all these side effects that happen. And this is where it's important. I mean, this is what I love doing all day, is to go through everyone's medications and understand, okay, yes, these medications are important. Absolutely. Mm-hmm. They have a level of importance. But if you're trying to, if you're taking these medications for a prolonged period of time, they can cause side effects. And side effects can actually be related to the heart itself. And this is where it's important to understand what's going on from that level of things. So as an example, if you become too deficient in certain things, then it can lead to an arrhythmia or an abnormal heartbeat. And so those are the things that we have to be worried about, especially when we talk about blood volume with ACEs and ARBs and blood pressure medications.
Yeah.
So,
and I'll just add one more thing to that,
yeah.
Diamond. Going back to these drugs is one thing that's important for your family doctor to follow up on is if you're started on a medication like this, we want to make sure we're watching your potassium levels as well as your kidney function.
And then this is where I was talking about what kind of leads into nutrient deficiencies. And so one of the things that I like to find out, especially, or what we like to find out here, is that if you do have high blood pressure, sometimes it's about getting into the reason why. Like, what is deficient with the reason why you might have high blood pressure? Are you deficient in glutathione? Are you deficient in any of these nutrients? Coenzyme Q10 is a big one, or carnitine, or calcium, or magnesium. Like I mentioned, is responsible for so many different biochemical pathways. These are the things that we start to get into, that this is where supplementation becomes important. And the interactions that happen with this are nothing. So if I start to supplement with zinc and I'm taking a medication, there's no side effects other than the fact that we will eventually, ideally, start to regulate your blood pressure, or even lower your blood pressure too much that we need to ease off on the medications. And this is when we start to get you healthier on that side of things. So, so let's get into talking about the nitric oxide pathway, because especially when we talk about blood pressure, this becomes very important, because a lot of these blood pressure pills, they do work on the nitric oxide pathway, but they do dilate the arteries. They do dilate the arteries so that we can have a hypotensive response to the hypertension that you're having. And so you can do this with foods as well. And so when you're taking nutrition, nitric oxide is NO. That's the goal that we're trying to get. And when we bring in foods, they are nitrates. And when we convert nitrates, it happens to nitrates to nitrite in the digestive tract. It becomes nitric oxide, and that's where your arteries start to use this. And so this is where L-arginine, there's another pathway that comes in. Please do not take L-arginine to increase nitric oxide pathways. That's very important. Do not take that. But this is coming down a different pathway, and I've done a whole talk just on hypertension on its own, so I can go through that. Or if you're interested, or you're part of a HeartFit University, you can get access to that part of it, how to lower your blood pressure naturally. These are important things to understand, that nitric oxide dilates the pathways. And you can do this naturally with foods. And one of my favorite foods I always talk about are beets. Beets is one of the biggest things that naturally dilate your blood vessels. And of course, the green leafy vegetables have a whole bunch of nitric oxide pathways. Sometimes there's a lot of supplements and nutrients, but none of these have an interaction with the medications that you're taking. So nitric oxide, the idea is that 100% nitric oxide gives you a nice dilated blood vessel. As you start to age, you start to deplete your natural nitric oxide productions, and you start to, like, these arteries are muscles, and I always bring it back to the highway analogy. Imagine your arteries like a 5-lane highway system. We start to close off or get construction on the side of the road. The artery is not expanding and contracting like it's supposed to. And so this is where nitric oxide becomes very important to healing the inside, what happens to the artery wall, and more importantly, dilate the artery wall. So this is where nitric oxide becomes very important. So alternative therapies, the big thing that we're worried about with alternative therapies is you going hypotensive, which is what we actually want, which is then we can back off the medical therapy, maybe cut your pills in half, or we start to maybe even get you off of medications, which we have done quite successfully a lot with a lot of patients. This is what alternative therapy does. And all those alternative therapies that I talked about there are things that we can get into. So, and I'm going to go back a little bit on this one here. So when we look at, addressing these nutrients, there is zero side effects that happen when we come to the medication and supplement interactions. There's no interactions here. But the concern that we have to be concerned about, again, is the getting hypotensive, getting too low of blood pressure, right? So those are important things. And then what if I'm normotensive? Do I still really require my medications? And that's something that we need to check in on. I think that's an individual answer that we should get into, because, ideally we want your blood pressure, your top number less than 120 and the bottom number less than 180. And some people have problems getting to that level, and they sit in this high blood pressure. We don't want you in this stage 2 or stage 3 type of hypertension, because 180 or higher is not so good. And 200 plus, I mean, I can't remember the statistics, but a lot of people get, I think it's one of the number one reasons why people get admitted to the ICU is for hypertension. So, but the question here is, if I'm normotensive, do I still require the medications? And I think that becomes on an individual basis, that we can see what happens. But do understand that these medications come with a lot of good benefits. And maybe it's just giving you a small homeopathic dose of that medication, just so we're getting the benefits of that medication that it's designed to do.
Right. And so the last one here that we're going to talk about with optimal medical therapy are statins. And I think I'll let you get into this one. It's your favorite.
So statins, but before I do that, I think this is important. There are a lot of cholesterol lowering drugs.
Yes.
There's the PCSK9 inhibitors where we can inject. There's the LDL, the statins, which focuses on this pathways. There's the fibrates. So ezetimibe is an example on this pathway here. So there's a lot of different ways that we can lower cholesterol. But before I do that, I always like to understand, well, what are the drugs? Maybe you can go through this part of it before I get into that. But
yeah. And so again, here you'll see 2 names for statins. And so typically, again, a statin, we call them statins for short, because that's typically what you'll find on the last, 6 letters of the word. And so typically statins, really what their job is to reduce that LDL. Many people will say that they will increase your HDL or your good cholesterol, but really that's very minimal. In most cases, it works on reducing your LDL. And really, ultimately, the idea is to prevent any plaque buildup in the arterial walls and ultimately reduce your risk of heart attack and stroke. But statins come with a lot of side effects, and that's what I'll...
And I do want to talk about the benefits, because I don't even think it's about reducing LDL. And I'm talking literature here. So there are a lot of trials, even the Fourier trial that came out and showed that we can get cholesterol off the map for people, which is the PCSK9 inhibitors. Yet we still see heart disease. And my concern with that is that people think that cholesterol accumulates to a pipe. And like I said, you keep on having a poor diet, and it accumulates to this pipe, and you end up with a heart attack. And it doesn't happen that way. But there are benefits of statins, and statins basically is to help. Remember how I talk about that cholesterol pack I talked about when we started today, how there's that small particles that sliver into the lining of the artery wall, and it slivers into the lining of the wall and it builds up like a pimple on your face. I don't have any pimples today to show you, so I'm all good. But the pimple on your face, if that pimple pops, that is a heart attack. The consistency of that pimple inside the lining of the artery wall is what a statin can help with it. And that specific pimple is called the lipid-rich necrotic core. And that lipid-rich necrotic core, that's why many of you, I recommend the Arterisol, is because the Arterisol helps with the lipid-rich necrotic core. But statins do have that similar benefit, and believe it or not quite the same thing, but it does have that inflammatory and lipid-rich necrotic core benefit. But the concern with that is that it comes with the side effects. Oh, you go with the side effects, yeah. Right,
well, they're all listed there. The biggest side effects that we often hear about is that muscle pain and that muscle weakness. And we'll talk about longer term side effects as we move on here, but that'll be the one that I'll point out for now.
So I just want to be able to make sure I'm addressing some of these things. And I saw some of these questions that came in earlier, so I'll get to that a little bit more. I know there's a question when we talked about blood pressure, 80 over 180, the top number should be less than 120 really is where we want to see. So diastolic is the bottom number. You'll always see that as the lower number in blood pressure, and the blood pressure, the top number is the systolic. So we usually go the bottom way around that way. So let's talk about, obviously there are a lot of side effects that can happen from statins. In fact, statins are probably the most prescribed pill in the world when it comes to that. There are many benefits, but there are a lot of side effects that can happen from it. And there are importance of cholesterol. So that's, I think, the first thing I want to talk about. It's essential to have cholesterol for cellular function. Yeah. The brain is 30% cholesterol and depends on continual production. So when we stop that continual production, this is where we can see the longer term concerns, which I know you'll go through in a moment. Mm-hmm. But it also is very important for the makeup of vital hormone dysfunctions. And I had a patient in our office, I think it was earlier this week, the days kind of amalgamate with each other. But when you look at this aspect of it, obviously they were on optimal medical therapy, and now they're starting to see the longer term side effects of being on these medications. And now we end up seeing some arrhythmia concerns because now it's affecting hormones. And so again, benefits of taking it, but the cons of taking it are very important that way as well.
And then the long-term risks, again, come with that. Just what Diamond was talking about here is that cognitive function, right? Because really, when we think about how much our brain depends on cholesterol, these are longer-term risks that can be associated with statins. And so it's not to say that they necessarily cause, but over time, that long-term effect can occur here, and statins have that effect.
Okay, so let's talk about this part of it, because gosh, I can probably talk the whole evening, the rest of the evening on this part of it, but why the numbers matter. So the relative risk versus absolute risk. So relative risk is what the drug companies are allowed to report based on placebo to the actual, the control group versus the actual group that are taking the drug. Mm-hmm. And if you compare those two groups, so let's say it's 3% versus 2%, then we know we have a 50% reduction in heart attacks. And so it sounds nice. But the actual truth of the matter is that understanding the absolute risk. And this is where we can talk about this a little bit more in depth. I'm not able to see the bottom of that slide. Hold on one second here. Either way, I'm not able to see the bottom. But anyway, there's the number needed to treat and the number needed to harm. How many people, again, I talked about this earlier, how many people need to be taking that medication to prevent one heart attack or stroke versus the number needed to harm? What are the side effects that can happen? And so how many people need to be taking that medication for one person to get harmed? And so that ratio is not so great, when we look at that ratio side of things. And so it may sound that I'm against statins, and I am a little bit, but I understand the benefits of them. And I understand the benefits to them because I know what it can do to the artery wall. But it makes me sad when I see such high doses of statins being given to patients or whatever it might be. It's important to get to the root as to what's going on and continually testing and measures so that we can give you the optimal health and getting some benefits still on statins on a lower dose, perhaps. So there are 8 nutrients that get deficient when you're taking a statin. And I don't want to go through them all, but these are important biochemical reactions that are important as the reason why you might even have abnormal cholesterol in the first place. And so magnesium, all these ones you can read here, vitamin D, the B vitamins, the carnitine, lipoic acid, inositol, choline, chromium. These are amino acids, coenzyme Q10, probably the biggest one that you hear in the literature, copper, selenium, zinc. So taking a statin actually lowers the energy metabolism, and that's where we start to see that part of it. And so these are the nutrient deficiencies. And so once again, if you're taking a statin, make sure you become nutrient efficient versus deficient. And when you take these nutrients, there are 0 side effects that happen when taking a statin. In fact, the only thing that you need to be worried about is grapefruit juice. And that's because it affects the same biochemical pathway that it has with statins. So it's kind of counterproductive on that side of things. But that is the one thing that we ask that you do not take in terms of interactions, whether you take it as a supplement or you take it as foods. So that's the only interaction that happens with statins. But taking any of these, there are 0 interactions that happen when you're taking a statin. And so let's get into supplements now. And so we'll talk about optimal medical therapy and supplements. And there are a lot of good things that you should be taking when we talk about that. And if you don't have it, I have a little ebook out that talks about our top 10 heart health supplements, which I can give to you guys afterwards. So you just need to, in fact, I'll just give it to everybody. And if you want to take a look at it afterwards, you're more than welcome to. So I'm going to let Tanya go through this part of it as we finish up probably the last 10, 15 minutes here.
Okay, so we're just going back to those first 4 classes of medications that we were referring to initially. So antiplatelets, commonly some depletions that we can see are the folic acid, vitamin C. So just what you see circled there, folic acid, vitamin C, iron, potassium, and zinc. And so these are some things that we know that it can become deplete and that we want to be able to replace. And I'll let you talk about vitamin K, Diamond, but
Yeah.
One of the things I would add here is micronutrient testing, right? That's why we do it, is because you could be deficient, or you may not be because you're getting enough of this in your diet. So it's really understanding where you are at as well.
And I think it's important when we're talking about vitamin K, I think we're most concerned about the antiplatelets for sure, but definitely the anticoagulants. And there are a lot of natural sources of vitamin K, but vitamin K comes in 2 different sources, vitamin K and vitamin K2. And vitamin K2 is actually the biggest in nattokinase and actually fermented. There's this bean, it's a Japanese soybean kind of focus. And that's where the biggest benefits of K2 is actually in nattokinase that way. But the natural sources, I think this is where it becomes important to just, I can't stress enough the compound effect of doing good things. Doctors sometimes tell you, be careful of taking green leafy vegetables when you're on your anticoagulants or on your aspirin, because it can thin the blood too much. But doc, isn't that what we want? And the truth is yes. But I'm a big fan of eventually getting patients off of these medications because we're consistent with taking these greens on a daily basis. The concern we have, and if you're not going to be consistent, that's where medications become important, is that, if you're consistent, you know that every day I'm having this many greens and this many nutrients in my body, and I'm consistent with at least 5 days a week, then we can know that we can confidently then consider taking you off or minimizing doses of medications. But vitamin K, again, comes in 2 different sources. And why we're told that is that the vitamin K2, which is also in these sources, are very important to artery health, which is so important, especially if you have a plaque. And this is where we can truly reverse heart disease. And this is where the plant-based kind of focus on eating is very important. Now, whether you decide to be vegetarian, I'm not a big fan of going completely vegetarian, but I am a big fan of getting your basic support with foods with a plant-based kind of way of eating. And you can add, if you like to eat meats, that's great, then add them in. But I would add them in a organic way and try and focus on getting some clean. We had this conversation with a patient earlier today, they're on keto diet, and there's a clean keto and an unclean keto. And that's very important to understand this part of it. But vitamin K comes in 2 different sources. And that's really what I want to talk about, this part of it.
And then some of the depletions that can happen with beta blockers, that next class of drugs that we were talking about, is depletions in CoQ10. melatonin, which is often, that's our natural, it occurs naturally in our body, good for our sleep, and chromium. And so those are 3 deficiencies that we can see, and then we'll go into some of the interactions.
So the potential interactions is if you're taking a beta blocker and you're taking a hawthorn extract or nattokinase, this can affect that part of it. Garlic obviously has a blood thinning effect on that side of things. So there, I'll be honest with you, garlic is something that I don't, but St. John's wort for sure. And green tea is something very important. And if you want to get a little bit more in depth, which is something that we can do in our clinic, is go into the genetic SNPs to see if you have the COMT genetic SNP. And if that's turned on, then we would say to stay away from green tea, because that's something that you do not want to take. But otherwise, green tea has a healthy component to improving artery walls on that side of things. So that's the depletions that happen with beta blockers and the potential interactions that can happen. So CoQ10, melatonin, and chromium, as Tanya mentioned there. Right. And then the hawthorn extract, for those people that don't know, aspirin, gotta be careful because it can increase the risk of bleeding, which is really the drug that's doing it, not the hawthorn extract. And then metoprolol, just lowering the blood pressure too much. So that's the hawthorn berry or the extract that's been recommended for heart health.
And then the main nutrient depletion that occurs with our antihypertensives or those ACE inhibitors, the one that ends in prils or the ones that end in sartan, the ARBs, is zinc. That's that nutrient that often gets depleted with those medications. And then some of the interactions are just as listed again, so similar to the previous slide. The one here that's really important is potassium. With ACE inhibitors and ARBs, because we're essentially telling the body to hold on to potassium in this case as part of that RAS system. And I won't get too complicated on you. I know we were throwing a lot of information here, but the potassium is one thing that we like to monitor when you're on these medications.
Again, the ACE inhibitors lowers your blood pressure. And so do these supplements as you get deficient on them. Sometimes you get too low. And that's where we may require a blood pressure medication change or lowering them off or coming off them completely. And that's where we see the benefits happening on that side of things. So zinc's the big nutrient depletion that happens there. So we talked about nutrient depletions in statins. These are the big ones that nutrient depletion happens in statins. And I'll let you go through the list there. But
yeah, so just as you see, CoQ10, vitamin E, vitamin D, carnitine, omega-3s, zinc, selenium, copper, and testosterone. So again, these are all things that we can check here at HeartFit with your micronutrient testing, but some of the potential interactions, again, are listed to your right. Actually, one of the supplements that we can use to help with cholesterol levels is that red yeast rice. And so being on that in conjunction with a statin.
You don't want to do both of them together.
Exactly.
Yeah.
Yeah.
Because it's the same pathway that happens on that side of things.
Right.
So the big question is, well, where do we find these high quality supplements? And, it's easy to go on the shelves and find them. And I think it becomes very important to understand the absorption of these supplements because, it becomes very important on that side of things. And there's so many questions that I'm sure you guys will have about, okay, what about this? And what about that? And I think that's all important, but the absorption becomes very important. So again, I want to reiterate and talk about, before we get into this part of it, how do we find quality supplements? I think there's a big importance to understand that there are supplements that you can take on the shelves and there are others that you can't. No, I shouldn't say can't. They're just not as efficient. They don't absorb as well. And so this is where it gets into looking at a little bit more of a pharmaceutical grade supplement versus something that you can find over the counter. But yeah, just be careful on that side of things and the absorption rate of that side of things. So again, just to reiterate, what is optimal medical therapy? We can get, I think we're going to do another presentation just on diabetes alone with Velvet. I know she was talking about that part of it. She's the one that came up with a lot of these slides here, and Tanya, of course, they did that together. And so what is optimal medical therapy? Of course, it's the antiplatelets or the antithrombotics, the beta blockers, the blood pressure medications with the ACE or the ARBs and the statin, but plus aggressive lifestyle therapy. And that's where it becomes very important to focus on, especially if you have artery disease, to focus on exercise, on ECP therapy, which most of you might have done in our clinic already, supplementation, getting on the right supplements with nutrients. Nutrition is medicine. Obviously, our cardiac yoga, meditations, getting good sleep, and obviously getting consultation. So you are always on the right path. It's about checking in and making sure that you're on the right path with that side of things. And so what are the lifestyle measures? Obviously, regular exercise, keeping smoking at bay, heart healthy nutrition, and addressing psychological factors such as depression or anxiety. And we didn't bring up the wheel here, and I forgot to do this at the, I was thinking about this as we're going through the talk there, is that depression has its own micronutrient wheel that, is so important to look at when we look at that side of things, because you could become nutrient deficient while taking a statin. Now it depletes a certain biochemical pathway that is leading to then depression. Right. And so those are the things that we have to be careful about. And that's where we can personalize that part of it a little bit more on that side of things. So I just wanted to bring this slide up, and this is a very important one, is to even what happens if because I think the biggest side effect that we've seen in our clinic is that, you know what, I can't exercise because I'm taking this statin and my muscles hurt. Well, I got to take this supplement or this medication, the statin, because my doctor told me otherwise I'll have another heart attack. Right. But I, exercise. Okay, well, what are the benefits? So I decided after Tanya found this great slide here on what statins do and what exercise does. And so cardiorespiratory fitness increases when you exercise. Statins don't do that. Your cardiovascular mortality decreases in both, so we get a benefit on both there. Diabetes mellitus decreases with exercise. It actually can increase with statins because of the biochemical and the nutrient deficiencies that happen with that. Cognitive function increases with exercise, which becomes important, especially as we age. There's no change or maybe even decreases of that. And we talked about the long-term side effects of statins. Your fall risk, which is very important, as we age, we start to fall more, it decreases with exercise. There's no change or might even increase with statins. There's a decrease in adiposity or tissue or fat mass. Obesity risk decreases, and there's no change with statins. And your quality of life increases with so your quality of life increases with exercise, and there's no change of statins. So if you were to pick between the two, and I've said this, and if you've read my book, if I were to put exercise in the form of a pill, it would be the most prescribed pill in the whole world. It wouldn't be statins. So food is medicine. We talk about that. And nutrition consultations is what we do in our office. So if you're interested in that, we can schedule that in our clinic. We can dive in deeper with this. But I know many of you have so many questions. And so in summary, before we go in there are minimal interactions to be concerned about when it comes to bleeding risk. And there are minimal interactions, but the big ones are bleeding risk, so the GI health, and hypotension, which is a good thing. So we just want to make sure that we then adjust the medications accordingly as we start to get your body healthier. And this should be watched by a healthcare professional, and all medications deplete micronutrients. I'll say that again, all medications deplete micronutrients. So it's important to test these, and more important, replenish these, because these deficiencies, and I see it so often, start to affect the electrical signal of the heart, and we end up with electrical abnormalities when we have artery disease. And that's a whole different discussion that we can talk about a little bit later. But as I said, I promised to you, if you stay to the end, that I'd give you a gift. And so I'm going to do that. And so we want to give you the best of both worlds, where medications and supplements can collide and be able to do that. It's supposed to be supplements on a leaf there. So yeah. And so they should collaborate. And so what we're going to offer you is a free consultation where we specifically go over your supplements and medications, because everyone's different. And we want to be able to get you on the right path of things. And so, as you know, we charge for these things and come into our clinic, and it's part of our program or treatments that we're already doing for most of you. But if you have not done this and you're coming into our clinic and you want to have that conversation, then please do that. Tanya can sit down with you, or myself can sit down with you, and we can go through understanding the supplements. What are the interactions you're taking? Are you on the right supplements? Let's go through that a little bit more in depth with that side of things. And the other thing I wanted to bring up is something that we're bringing to our clinic as well, is we have our monthly membership program. And what is included in it is, so for either $200 or $300 a month, we have our monthly webinar coaching sessions like this. You would have preferred pricing on our assessment packages and assessments and supplements. Obviously, we do monthly check-in with exercise, nutrition, and supplements. And the difference between the two is that we do a yearly assessment on the right-hand side. But the offer that I want to be able to do for you today is, if you are interested in this, it would be $99 a month to do the following. And of course, most of you are taking that in supplements, so you would save that in the supplements a month anyway. But that's just an offer that I'd like to be able to do. So thank you for being one of the millions of hearts we have hoped to help and help you live happier, healthier, and longer. So we'll stick around today and we'll answer any questions that you might have today to go through anything there, and we'll go through that. So
awesome.
So thank you very much. I think we kicked it right inside an hour, so that's good. And I'll let you, if you want to unmute yourself, you can, and I'll go through all the questions there that you have. And thank you very much.
We've got a few that popped up in the chat box here. So one of the questions that I saw is, would you recommend staying away from anything that would cause thrombosis? So this is one of those things, again, that's quite multifactorial. There's a few things that can cause thrombosis. I guess the biggest things I'd say is sitting around for a long time. That's something that's been happening around along with COVID, right? Everybody, for a lot of people, they've been at home in front of their computers, sitting down. And the biggest thing I say is every 2 hours, get up, move, do some jumping jacks, because sitting down for a long period of time, especially 3 hours or more, that's where you put yourself at risk for having a clot in your leg that could potentially travel up to your lung. And it really is that same sort of process that occurs and could potentially either lead to other damaging issues with your vessels. So that's one thing that I can think of. I don't know if there's anything else you would add to that for what would cause thrombosis, but.
So being away from anything that would cause thrombosis, yeah, I think, we're always worried about, from a thrombosis side of things, maybe compression socks would be something to consider. And especially if you are traveling a lot in the plane or starting to get on some long haul flights or anything like that, make sure you wear compression socks to move around. I think that becomes important that way too. And then stay hydrated. I think that's the other thing I would add there.
And if you're smoking, you got to quit that. But we can talk about that. That's not always the easiest thing to do. And we know that our brain has certain receptors in it that have nicotine receptors. So if you're smoking and you're used to doing that, your body literally gets mad at you for trying to quit. So there are ways to get off of that and that we can talk about as well, if that's something that you want to think about.
So I see a lot of comments here. Thank you very much. A lot of people sent messages personally, but thank you very much for the birthday wishes. I appreciate that. I think as you get older, I think it's not about getting gifts. It's about, I got a great gift from a great friend, and she gave me a nice gratitude journal, and it's really fun to go through that part of it. And you become more grateful for what you have. And I think it's more of a reassessment every year as a birthday. I actually look forward to, because I wonder what I accomplished last year. And so I'll share with you 3 things that I wrote down that are very, that have made a big move in what we've done in our clinic. So number 1, we hired a medical director for both our clinics now. And so we have Tanya as a nurse practitioner here in our clinic. So that's 1. Number 2, we moved into a new clinic in our Calgary location. And number 3, we opened up our Vancouver clinic. So those are the things that have happened all in 1 year that way. So anyway, thank you very much for all those birthday wishes. And I always like to share a little bit about what I think about on the birthdays. Can the procedure be done on the artery? I think he was talking about heart stents there. Yes, stents can be done in other places other than the heart. We can put stents down into the lower limbs and extractions that way. But again, you have to be on the antiplatelet therapy, and that's something that can happen on that side of things. External counterpulsation can help out with that, but it takes a lot longer of treatment options. You're looking at probably, in my experience, closer to 50 treatments, if that's be the case, to do that, to improve the peripheral artery disease, but also exercise. Exercise becomes very important, and you can push yourself past those thresholds. The number needed to treat of 357, how did I get that? Those were just literature, just from the studies that came from there. So that's where that came from. Where are the slides? I'm giving a copy of the video. So you'll have a copy of that tomorrow. So you should be able to see me talking. So I'll say hello for the next day there for you guys. So you can watch me again, us again, both there. We talked about diastolic blood pressure. So the blood pressure, there's a top number and bottom number. And then, if you are interested in the book and the slides, please talk to my staff. They'll get you on that side of things. They can give you those things. And specifically, the one thing that explains the arteries, the 8 things that becomes depleted when taking a statin. I think we went over that on that slide. So I'm going to bring that back on that right here. So these are the big things that get depleted when you're taking a statin: coenzyme Q10, vitamin E, vitamin D, carnitine, omega-3, zinc, selenium, copper, and testosterone. So I would recommend that if this is the case, that you consider talking to the clinic or coming into the clinic and looking at micronutrient deficiencies, because not everyone gets depleted on this. And there are always some things that some people are taking that may not be taking. So this is where, if you want to be generalized, then take all of this. But if you want to be more specific, then we can do a micronutrient test and get specific on taking the correct one as deficient for you. But if you were to pick one of those, gosh, there's really good ones there. But I would say, CoQ10 and omega-3 and vitamin D and zinc and God, like they're all very important. And this, we're coming into flu season. I think what we'll do is we'll just do a quick webinar on flu season coming up now, because we're in Calgary, at least we're in the midst of a 4th wave of COVID. And whether you're vaccinated or unvaccinated, you're still at risk of containing an immune response. And so you want to make sure that your immune system's strong. And so I think we'll do a webinar on that. We'll do one of our free ones. It won't be part of our monthly coaching sessions, but I think it's important, just come flu season, that it's important to be able to take control over that and getting on the right things on that end of it. You're welcome. Thank you for all the nice comments there. I appreciate that. If you're again interested in the book, you can contact our staff. There was a question here. I take 10 milligrams of Crestor. I eat grapefruit very frequently. I've been told by my doctor to stop grapefruit with another medication. I believe it was warned I would stop grapefruit. And if you like grapefruit, then I would consider coming off of a statin and going on a healthier nutrition side of things, because or maybe even depleting or lowering the dose of the medication that you would be taking. So I would come off of grapefruit, because it actually is interactive in a negative way to the statin, so you don't get the benefits on that side of things. So my answer is to either get off the statin or get off the grapefruit. And grapefruit has a lot of good benefits to you. But and that's where we can have that conversation a little bit more in person and go through that side of things and see what might be best for you. But the statin's not for everybody. It comes with side effects, and if you don't want to take them, then there are good supplements that you can take that we can talk about more individually. Welcome. Thank you very much again. All those things. I saw a good question here. What are the issues of taking quercetin? None, other than it helps your immune system. So quercetin is actually really good. Can you send me the 2 membership options? I will send you those 2 membership options there. So the 2 membership options that we have in our clinic now that we just released is, we've got lots of good things that we have in our clinic, but this is it here. And this is the deal that we're giving to you guys. So for 90, and for those for those of you who are on our monthly membership, we usually charge $49 just for these webinars alone. And so it includes preferred pricing on our assessments. So you'd pay that back off if you're obviously reassessing and checking it, on supplements as well. And then we have monthly check-ins. So you get to check in with a nutrition, with our nutritionist. You get to check in with exercise on something, or you get to check in medically with something if there's something going on that you want to talk about. So it's just a way of, look, heart disease loves to progress. We like to reverse it. And it's a battle, right? We got something that wants to push that way and be progressive, and we want to reverse it. And so we just have to have those check-ins and just make sure that you're on the right path. And this is where it allows us to be of great service to you back and forth on that.
And I would add, it's hard for us to give a blanket approach and say, well, this works for everybody. And that's where it really is important to sit down with you individually and go through what your history is. Why are you on certain medications? Because you may be on something that you need to be on, or you may be on something that you don't need to be on. So.
And then, the monthly check-ins, with medical, like I mentioned, we're already giving one of those. If you want to do this later, that's fine. Just say, hey, Darwin, I'm interested, or our staff just say we're interested in doing the monthly membership. But I'm already offering you to come talk to us to go over your supplements free of charge, or go over your medications, or go over some things that are important. So take advantage of that, even just get an idea as to what's going on with that side of things and be able to do that part of it. There was a good question here. Any comments on fasting and Ramapril?
Fasting, I think the one thing that comes to mind when I'm thinking about that is, if you're fasting, are you drinking water? And if you're dehydrated, I worry about the effects of that ACE inhibitor on your kidneys, along with being dehydrated. So that's the first thing that comes to my mind when you ask that question. I don't know if that's helpful.
Where do you get carnitine in your diets? I think it's important. A test that we do in our clinic is looking at TMAO levels.
Mm-hmm.
And if that is elevated, then you should be staying away from carnitine. But carnitine is found mostly in animal protein sources. So you'll find them in chicken and meats. That's where you'll find them most. Again, thank you for the birthday wishes there. Appreciate it from everyone there. What are the deficiencies this Coversil cause?
So Coversil, if we can go back to that slide with the ACE inhibitors, the side effects. So Coversil is that's the brand name for prindopril. So again, anything that ends in pril is an ACE inhibitor. So we'll go back to the slide there, but essentially there were just a few, and the biggest one, we'll wait till we threw a lot of information. So I'm sorry if this is overwhelming too. It was a lot for us to try and tease out what we should talk about and what we shouldn't, but we'll break this down some more in the future. So going to our ACE inhibitors here. There we go. No, sorry, Diamond. It was the prindopril there. The biggest side effects, or we're looking at deficiencies. So it'll be the green side. I'm so sorry. We need to go back down, but I don't remember it all off by heart. We'll get it here.
The green slide, right?
Yeah,
Sorry,
yeah.
Let me go back here.
Okay. Yeah. There we go. That's beta blockers. Down one more, two. There we are. Okay. So the deficiencies are just as you see it here, and that main one was zinc. So if you want to look at that slide. Some of the other things, and again, a CoQ10 and fish oil is not bad when you're taking an ACE inhibitor. It's a good effect, but it can have an effect of decreasing your blood pressure. So that's one thing is if we're having a good effect on your blood pressure, that's okay, but maybe we can start to then back off on your ACE inhibitor. Again, this is something we would do. We wouldn't just tell you to go and do. We need to make sure that we're monitoring you. Good thing to do is have a blood pressure machine at home and even check that regularly. I usually suggest, if you just started on a blood pressure medication, is taking that blood pressure regularly, once in the morning before you take the medication, and then maybe later on in the day, same time every day. If you can just make a routine of it, keep track of it, that's very helpful for me to see.
So someone's asking us, what are all the services that we offer? And maybe someone hasn't come into our clinic, and I apologize for not going into it. I just really wanted to get into what I promised to talk about today was obviously with the medications and supplements and interactions, and hopefully you kind of got an idea on that part of it. But the services that we do, we see people who are concerned about their heart health, and that could be anyone who is just preventative to people who have established heart disease. And we provide heart assessments and treatments that bridge a gap in the healthcare system. So you're not going to find the same thing that we do in the healthcare system to prevent and reverse heart disease. And one of the questions that I also saw was, micronutrients. And why we look at that is to find out specifically, it's a blood test where we look at it on an intracellular level. So we're looking at it right inside the intracellular. So let me talk about that for a moment. When you test something serum, so if I take a blood test right now for myself, it is serum. It's based on what I had for dinner, at lunch, at breakfast. I can see it wildly fluctuates daily as to what I have. Mm-hmm. Intracellular, what we do is obviously we send the blood work outside of us, but we actually open up the white blood cells and we grow that specimen for a few days, almost a week. And then we get to see what's right inside the white blood cells. So it gives us a long-term average as to where your deficiencies are. And so that is a blood test where it looks for intracellular nutrient deficiencies. So we get to see a long-term average as to where your deficiencies are. And so that's what we do for micronutrient testing. But there are an abundance of other testings that we do to see where your risk is. We're really the only clinic that has testings that focus on where your risk is of a heart attack or stroke, where the health is of your arteries, and then what we can do to reverse that disease process.
Good questions.
Yeah. Anytime I need to fast to lower my ramipril or get dizzy or blood pressure goes very low.
So
I think,
that was referring back to the fasting and the blood pressure.
Yeah, and I
Which
think-
makes sense.
yeah, and that makes sense. And I think, I think that's where it would invite, I think you would benefit just coming down in the sitting, going over everything that you're doing and what's going on, because if you're getting dizzy and your blood pressure goes very low, then obviously it may be time to consider weaning off of some of the medications that way. Possibly. Just don't do it on your own.
Don't do it on your own.
Yeah.
Yeah. We like to watch that stuff. And of course, I also too always say I like to work with your family doctor, right? This is not to step on anybody's toes, but really to be collaborative in bridging both worlds of medicine as well as the lifestyle and alternative world.
Excellent. I think we might have addressed a lot of them there.
Any last minute questions at all while we're still here?
Excellent. Well,
Really great feedback.
yeah, thanks for, I know we probably had close to 200 people that registered, maybe 280, I think it was. So I don't think we have that many on today, but I know a lot of people are waiting for the recording. So thank you very much for coming into the clinic. We look forward to seeing you in Calgary, in Edmonton, in Vancouver, wherever you are closest to. So thank you very much. For those of you asking, I am in our Calgary clinic today. That's and I'll be in Vancouver. I usually love to go. It's such a beautiful city. I love flying in there every time, and makes me feel happy when I come in there and to help you guys as well. So
there's one more question there about, can we do virtual meetings? Yes.
Yes, we can. Yeah. So our meetings can be virtual on a platform like this where it's confidential and we go through your situation that way. So absolutely. We do a lot of, especially with COVID, you know, it takes us back to, I think the word that I think about COVID is pivot. And it takes me back to that. For those of you who remember Friends, the episode of Friends with because we were moving into the clinic and Ross was, you know, trying to move that couch. That's pivot. And so one thing we've had to do really well is pivot. And so it takes me back to that funny episode of Friends. So anyway, yeah, we can do virtual meetings, even if you are close to our clinic and it's a challenge to come into our clinic for traffic reasons or transport reasons. We can definitely do it that way too.
Awesome.
Well, I think I've kept you guys here long enough, and thank you very much for being patient with us. And I thank you all again, once again,